I'd like to transition to show you what the capability of the Javelin catheter is in the superficial femoral artery and popliteal artery space. This is a 75-year-old female who is a nursing home resident with high blood pressure, high cholesterol, as well as diabetes and end-stage renal disease requiring hemodialysis. So while at the nursing home, she developed dry gangrene of her left heel. She had non-palpable pedal pulses on physical exam and grossly abnormal preoperative vascular lab studies that you can see here. So the images clearly show dry gangrenous changes of her left heel, along with severely abnormal ABI and a toe pressure of 0. She was taken to the operating room for a lower extremity arteriogram, again done through a contralateral femoral approach, which demonstrated diffuse superficial femoral artery occlusive disease. There was occlusion of the popliteal artery, and once again, diffuse tibial artery occlusive disease was identified. She did have an occluded posterior tibial artery, but as you can see on the image to the far right, she did have a diseased but intact plantar arch, which was providing retrograde flow to the heel via the plantar branch. And that's why we elected to proceed with endovascular intervention here in an effort to provide increased perfusion to her heel. So in the process of selecting the superficial femoral artery and attempting to pass through the occluded SFA pop segment, we were able to pass an 014 wire through the occluded segment, but I could not pass a crossing catheter, nor could I pass a balloon to perform balloon angioplasty on the occluded segment. So as you can see to the image on the left, the wire is through the occluded segment, but I could not successfully pass either a crossing catheter or a balloon device in order to establish a flow lumen. At this point, I elected to use the Shockwave Javelin catheter in an effort to cross through the occluded segment, deliver lithotripsy pulses, and establish a flow lumen so that we would be set up to facilitate definitive therapy. So the images to the left demonstrate what we were able to do while advancing the Javelin catheter through the superficial femoral artery and the popliteal artery. The Javelin catheter was brought into position over the 014 wire. With this in the position in the most difficult segment to advance through, we simultaneously delivered lithotripsy pulses while advancing the catheter through the occluded segment. We were able to deliver 60 pulses while advancing the catheter antegrade, and then an additional 60 pulses slowly while retracting the catheter over the wire. Following this, we established a flow lumen through the occluded segment, and then were able to very easily advance the balloon to perform balloon angioplasty of the occluded superficial femoral artery and popliteal artery segment, which then set us up for successful definitive therapy with balloon angioplasty and stenting on the previously occluded SFA pop. And the completion images you can see here demonstrated an excellent technical result with a widely patent SFA pop segment and no significant residual stenosis identified. We were unable to cross the anterior tibial artery in an antegrade fashion from an up and over approach, and therefore I performed retrograde pedal access to successfully cross through the proximal anterior tibial artery, which was treated, and the completion arteriogram demonstrated a widely patent anterior tibial artery with flow into the foot and no significant residual stenosis. So at the completion of the case following removal of the retrograde pedal access sheaths, she had a palpable dorsalis pedis pulse and a posterior tibial artery signal from that retrograde plantar flow where there was none present preoperatively. So she had a very good radiographic result from this procedure. And Javelin catheter allowed us to really facilitate successful definitive therapy on that SFA pop occluded segment.